We are live now. So
I think you can go. We are hearing you very well.
yes, yeah. So it's always a pleasure to welcome everybody. And today we have a very distinctive speaker, Professor Mario Romano from Italy and Professor Magdy Moussa from Egypt. And we will discuss both a very interesting subject. And we welcome also our attendees who are coming now. So we also like to thank our association and our sponsor, National Guard, Bayer, RSOS, and live presentation with the Association of the Saudi Retina. Today we will have Professor Mario Romano from Italy. He will talk about the COVID-19 lockdown and restart phase in ophthalmology. Also, we will have Professor Magdy Moussa from Egypt. He will talk about the OCTA fact and artifacts. Professor Mario, you can start your talk.
Thank you. Let me share my screen first. Can you see my screen?
Yeah,
Yes.
we can see.
Very good. Thank you. So thank you for your kind invitation. So as you know, in Italy, in particular, the place where I'm working, so this between Milan and Bergamo, is facing this dramatic challenge of SARS-CoV-2 virus. And we were the first, epicenter in Europe after China. And so the situation was not easy for the last 2 months. Currently, we cannot really provide still a complete review regarding, the ophthalmology, because the field, regarding the COVID-19 is under rapid evolution. So with daily scientific publication. So today I'd like just to share with you our previous mistake and our current knowledge on the topic. So the outline of my presentation will be the lockdown first, and then the phase 2 so restarting. So as you know, SARS-CoV-2 outbreak was declared a public health emergency of international concern by the end of January. The first Italian positive patient was on February 20, and then after a week, we are, in red zone. That means, the lockdown was a complete lockdown, and we are every day looking to this R number. So R number is the number of healthy people contaminated by each SARS-CoV-2 infected person. So the aim of lockdown was to avoid numbers of serious acute respiratory syndromes to get more time for effective patient care and reorganization. So at the moment, we are here. So we have around 200,000 positive, but we think that is underestimate, and we have 27,000 dead. And also, we had experience of a colleague that was in our department that died because of coronavirus. So the first point, are the surgical mask. Very important, for the patient, but, for us is a different things. We need to wear FFP2. The point is just the filtering capacity, because the surgical mask has a good filtering capacity towards outside, so like 95%, but not towards inside. And so this is good for the patient, but we need to use, FFP2, that is an acronym for filtering phase piece. And now, according to the recommendation of American Academy of Ophthalmology, SRS, Royal College, and many others, for all ophthalmic procedures of healthcare staff, we need to wear this mask. There's a difference between a mask FF2 without valve, a with valve, without valve, the filtering capacity towards outside and inside is for both very high, between 92 and 98%. But with valve, the filtering capacity is good towards inside, but towards outside is very low. So we need to keep in mind these things. So surgical mask for the patient, FFP2 for us. And then you all know about general PPE that was very important in the first phase, you know, in the complete lockdown, but is also important in the second one. And so we are speaking about long gloves, long sleeved waterproof gown, ocular protection, goggles, because we need to use ophthalmoscopy indirect. And so with the face shield is not so easy to use. So goggles probably, you know, is better for the ophthalmologist. And also we need the slit lamp bed shield and FFP3 mask. Also, we need to keep in mind that the coronavirus is detectable on the surfaces. You know, if in the hair is just about 3 hours, on the plastics about 3 days. So we need to use ethanol 70%, sodium hypochlorite at 0.05 or 0.5%, because it's very important, the sanification. So the first point is the role of the ophthalmologist in intensive care unit. Because of a prone positioning, we can have, of course, corneal injuries, but it is easy to treat with the lubrificant drops or with Steri-Strip. The point is sometimes we can have occlusion, artery occlusion, or ischemic optic neuropathy because of the severe systemic hypotension, hypoxemia due to the respiratory distress syndrome, also because of prolonged prone position. So if you are asked to go in intensive care unit, have a look to the retina, because sometimes, you know, we can have this occlusion. Regarding the clinical findings, you know, really the conjunctivitis is not really a big matter, because it's like a common cold or an allergy. So what you can see is follicles, but you know, the follicles are just hyperplastic lymphoid tissue. And so that they are characteristic of COVID, of conjunctivitis as other conjunctivitis, but you know, we cannot see papillae. That's completely different, not present in the COVID. So, but we know that according to recent publication, that the oral mucosa is not only the site of the virus entry, but also, you know, the replication, the site of replication. So this is very important according, you know, to what we need to do for our protection. We are running now a protocol because we know that the inactivation of SARS coronavirus is also done by povidone iodine. So in Europe, we have this drop that are povidone iodine 0.6% that is used as a device, but also ozonated vegetable oil drops that probably can be useful as antimicrobial, antiseptic for activity to protect the healthcare staff. So we are using, you know, when we see the patient to have a barrier, you know, against the virus. So what about the phase 2? So the aim is to minimize the viral spread in our clinical surgical activities. So in this phase, we are looking to the low-risk population according to serological screening. We are looking to the contact tracing app that are now available, and also we need also to healthcare personnel, you know, monitoring with the swab throat swab at least every 2 weeks. So regarding an important point are the immunity in COVID-19. We know that coronavirus are zoonotic. The intermediate host is the pangolin, and then the spike protein of the virus acts as anchor to the ACE2 enzyme, and then the virus enter inside the cells and then get replicated, you know, with the viral RNA. But the problem is the immunity, and we know that the innate immunity doesn't work well with increase of neutrophils, decrease of lymphocyte and interferon, whereas the adaptive immunity mainly is working through the T helper 1, but the antigen presenting cells, class 1 and class 2 HLL, doesn't work well. So at the end, it is important because the duration of a viral shedding is between 8 and 37 days, and we need to keep in mind as ophthalmologists, because we still have positive patients, asymptomatic. And so that's why now also the assessment of immunological memory is important. In general, we know that the IgM indicates a recent infection, whereas IgG appears, after the first 2 weeks. There's a recent publication just, a few days ago that, the seroconversion for IgG and IgM for COVID-19 occurred simultaneously or sequentially after 13 days post-symptom onset, and within 19 days after the symptoms onset, 100% of patients tested were positive for IgG. This is very important because it can be really useful as screening, epidemiological screening. Because between 30 and 60% of infected can be asymptomatic or pre-symptomatic. So just the screening according to the symptoms is not enough. That's why the immunological tests are very important. We published this paper recently looking to the ophthalmologist high risk and to the outpatient clinic, because the respiratory droplets slit lamp, and because also at high risk population according to the age and comorbidities that we are seeing every day. So this is an algorithm that we sent for is under submission. And how can we managing the patient? First of all, with the virtual triage. So we are doing the first stratification, and we are doing with the general triage on phone, and this is done by secretary of outpatient clinic, asking about if the patient has been in contact with the person or suspected to have coronavirus, if they have cough or shortness of breath or temperature. And then we are going for ophthalmology triage with trained nurses with ophthalmology support. And then regarding the assessment on phone, so we have a general assessment, and if one between this question is yes in the general section, the patient will be referred to have a throat swab. Regarding the ophthalmological assessment, in case we have one yes between these questions, the patient is admitted to the eye clinic pathway. So the aim is a patient certification system. Which one we need to see face to face, which one we can rebook in 3 or in 6 months. And this is the table that we've published in the paper according to low, medium, and high risk, and according to the fields of cornea, glaucoma, or cataract, vitreoretinal, and if it's a clinical problem or surgical problem. Then the second step is telemedicine. If we can manage with the patient with telemedicine, we can get information from home delivery care, so video, phone calls, consultation, but also self-assessment, we will see later on. And also, we also use this specific imaging pathway for the second phase. So that means we can get information with the OCT, for example, with the imaging performed by technician in peripheral spoke, and then we can review the imaging and according with in a virtual clinic with the patient. So regarding the self-monitoring, we are now on the tablet and on the smartphone, self-measuring best corrected visual acuity, but also metamorphopsia charts. And then we can go for then a consultation virtual clinic. But also, as I was telling before, specific imaging path, so images collected by technicians, and then, we can use, in the virtual clinic, but we can also use in the artificial, intelligence imaging review, deep learning and machine learning. So the patient that we need to see, that we cannot go through the telemedicine, but we need to see face to face, they go through the triage on site, of course. And for inpatient, we need to have a throat swab. So if it's negative, we can do surgery. If it's positive, we need to do the surgery in a hospital that are just for COVID. Regarding the outpatient, so we go first for serological tests, so screening with just screening and epidemiologic purpose. And if the patient are positive for EGM or EGG, they need to go also to the throat swab. And we also ask the patient to get this tracing app that we know that works just if more than 60% of the population get this app. And and it's based not on GPS, but on short range Bluetooth communication. So we are also some advice for the personnel pathway. So the serology, as I told you before, every 2 weeks. And then, of course, to be readmitted if one of us were COVID positive, had to have 2 consecutive negative PCR on swabs. Regarding the visit protocol, of course, reducing waiting times, conversation not at slit lamp, using of monodose eye drop and proper disinfection. Also simple things like keeping all the doors open. Regarding the environment, we need to keep in mind about the elevator. That is, a really, bad place because, a lot of people and in a small, room. And also we need to also think about proper ventilation of the room, consultation room, and also probably can also help the UV because there are some recommendation about also the activity on UV as microbicidal. Regarding the staff organization, we recommend also to split the staff in 2 segregated teams, COVID positive and COVID negative. Also, the COVID negative has to use the PPE, but this is important because, the high-risk cases and colleagues, because colleagues that in private are in contact with the increased risk people should be allocated to low-risk areas, so working remotely or with the COVID negative. What about the surgery? Of course, we can use a drape to reduce the aerosol spray during the surgery, but we need to keep in mind that as we move then the drape, the virus can be reatomized into the air. And also there are some concern about the aerosol generating procedures like vitrectomy and phaco, but we don't know much about that. Alcon Medical Affairs team stated that phaco and vitrectomy are not considered AGP, so aerosol generating procedures, but still we need some confirmation about that. We are working also to regarding the operating room in a project because we know that normally the operating room are over pressure. Now we are working to get an operating room under pressure in order to don't spread the COVID around. So with the low air infusion, high air outflow through the vents. And finally, a few words about the dedicated screening program after COVID-19 infection for the people that recover well. So we know that according to our protocol, we are using anticoagulant and the platelets because there is an increase of D-dimer, so that means increase of occlusion. And we also using Caletra, that is ritonavir and lopinavir, and hydroxychloroquine, that both can get, bullseye maculopathy. So we are using hydroxychloroquine and Caletra for both. They have, a iatrogenic, can have iatrogenic damage on the retinal pigment epithelium. And for both, in chronic use, has been described this bullseye maculopathy, as you can see also in the picture. Hydroxychloroquine has the same target, and we don't know anything about the interaction between hydroxychloroquine and ritonavir. It's been published, for example, that hydroxychloroquine has interaction with tamoxifen, and the odds ratio is 5. So we don't know really if there is any interaction. It's also in acute phases, not in the chronic phase, between hydroxychloroquine and ritonavir. And another toxicity can be done by tocilizumab. This is a monoclonal antibody, because it can also get cotton wool spots and retinal hemorrhage. So now we are running this awkward screening program. So because on baseline 6 and 12 months with the COVID negative patients, so the patient that were COVID positive and then recovered at the swab was negative. So, and they are under this awkward screening program looking to synergic toxicity of the hydroxychloroquine and ritonavir, but also possible vessels occlusion because high D-dimer during the infection. So so the problem now, we think that eye is not really the target of the disease, because the trophism of the virus is not so high for the eye, but the main concern are mainly for the ophthalmologist, because also we had in our department a colleague of us that really had a big problem and had the hand he died for the COVID-19. So we really, want to make sure that, for safety of our safety and the safety of the high-risk population that we are treating, the second phase we will go, as in the best way. And so, thank you very much.
Thank you very much, Professor Mario Romano. Very interesting experience, and it carry within its page a lot of sadness. As you told me, some of your staff has been a victim for this pandemic, isn't it?
Yeah, many of us were positive, and one, unfortunately, he really had a big problem, and at the end, he died for the virus. Yeah.
If I said in a department contain like 10 person ophthalmology, how you expect how many of them will be positive?
So for us it was a different problem, because we were the epicenter, and we really didn't know how the outbreak was, and we didn't know that it was so strong, and we really need a high protection. That's why we are always saying the same things. The problem is not the eye, the problem are the ophthalmologists. So, and we think about probably 70% of us were positive. Yeah.
Oh, I see. So it's 70%, isn't it?
Yeah.
Oh, I see. When do you think you will go back and operate cataract? I know there has been a release now lifting the curfew in Italy.
So, yeah, so we are starting gradually, but I think cataract probably in a few weeks. I think 2 or 3 weeks we will start again with cataract. I mean, elective cataract, the normal cases, but or in case of phacomorphic, phacolytic, we are start as soon as possible, not in 3 weeks time. And but we are asking to all of them, even for cataract surgery, to get first the swab and the PCR to be, sure that they are negative, because, the problem then they can spread between the patients, between themselves and, staff. So really, we are very, very, careful about that.
Thank you very much. I think at the time of the discussion, we will answer. We receive a lot of questions, and we will keep them till the end of the talk. Professor Magdy Moussa, we will start our interesting talk of the OCTA. A lot of people thinking to open their own clinic, and they are wondering, should they include an OCTA in their budget or no?
I'll be glad to answer that at the end of the lecture. Shall I share my screen now?
You can share your screen after I did a poll for all the audience.
Okay.
We will launch a poll. Please, we need all of you to vote first choice or second choice. So the poll is saying, do you think early restart is better or delay as possible as we can, even if it's going to affect the economy? You have two choices. Either you early restart or postpone it till the end, even though if it's going to affect the economy. The choice is early restart or delay. Okay. So we will stop now, launching the result. So the majority, it's like 1/3. It's like 1/3 with early restart, and 2/3 is with the delayed restart for the security reason, even though if it's going to affect the economy. Okay, I will let the OCTA since many years now.
5 years, almost.
My question is, how frequent you still doing the fluorescein angio after you get the OCTA?
Actually, I'm a referral center, so in my cases, I cut down almost 50% of my, fluorescein angiography, because I can rely on examination. I'm not seeing only machines, fundus examination, biomicroscopy, and then doing the OCT and OCTA, especially in the central lesion, like CNV, like macular degeneration. In the periphery, though we have a wide field now, 12 by 12 millimeter, but still it is not that easy to do. But again, in the central lesions, I can in 50% rely on OCT, structural OCT, and OCTA and biomicroscopy, and I think I can reach the final diagnosis by these tools.
Great. Do you still giving an intravitreal injection in this pandemic, Professor Magdy?
Actually, I do. I stopped for 2 weeks exactly when we started. That was March 4th. And then after 2 weeks, I have many calls from my patients. And I go to the files and I would know if this patient exceeded a couple of months, because some of the patients stopped coming in when they knew that there is episode or the pandemic. So they stopped by themselves from February. So once the patient passed the 2 months, I would ask him to come in alone. And I would ask him again, if he has any, people around, he traveled, we had any contact with any people who might have the infection, and we have endemic areas around us. But if not, I would bring the patient in, I would do OCT, and I will inject him. But the problem is a lot of patients had missed many visits, and that's why I'm getting this month, at the end of April, I have many patients who missed the appointments, and they already complaining of diminution of vision. So I start to inject once I find out that the patient is complaining, and I bring him in. And once I find there is progression, especially the CNV, diabetic macular edema, I don't worry much, because I would know that they can stand still for a couple of months. But the CNV, most of the patients, I don't think they can afford staying more than 2 months, and they have to come in.
We totally agree with you, even though this is my personal feeling, Professor Magdy. I know there is some guidelines only dedicate the injections for AMD, and maybe Professor Mario also, have you still injecting the AMD, I think, isn't it?
Yeah, so for a while we really, because we were a COVID center, we couldn't really even inject the patient, but you know, in many places around us, because we were, you know, the epicenter, still, you know, are doing it, and we are starting, you know, really in a few days now back to inject the people, but really it is one of the you know, thing to keep, you know, doing it, because otherwise, you know, as like retinal detachment or a few others, you know, pathologies that we need still, you know, to keep going treating. Otherwise, you know, we will not get vision back then. Yeah.
Okay. Okay. We will run a vote actually. We will share you the result of the previous one. Then we will ask another question for the audience, please. So the second poll, do you have a fear regarding the restart that you will get infected? For example, if you restart working, are you going to, do you have a fear that you will get infected? Does this play a role exactly emotionally on your first day that going back to work? I need from all the audience to vote, please. So this question is even if you take the protective measure, even if you have the mask, if you have the gown, if they have everything. So the result is, we will share the result. So 76% still afraid, even though if they take the protective measure. 27% actually they are feeling okay to restart. So this pandemic has emotional effect, has economic effect. It disturbs everything in society and in the country, I think.
Yeah,
and it disturbs the thinking.
Yeah,
even your thinking is changed.
Yeah.
This is why we call it the new normal.
Right.
You want to say something, Prof. Mario, please?
Yeah, I have been going in the last 2 months to the hospital. I was not doing, you know, ophthalmology, but I was helping in other things, and really, you know, was a COVID center. If you use, you know, the PPE is safe. The point is that sometimes, I mean, we lack of PPE, and this is the main problem. But I think it's time, you know, we have been locked down for 2 months. I think it's time to, you know, go back, you know, to our patients, to our clinic. But, you know, stratifying the patient using PPE, I mean, it's time to start. Otherwise, you know, we cannot wait for 6 months. So we cannot wait when the virus will be completely, you know, the outbreak will completely, you know, shut down. So I think it's time, because we have to, you know, take care of our patients, but, you know, with the real PPI protection and all the things that we need.
Okay. May I add something, Dr. Abdullah?
Yes, please, please.
I totally agree that we have to come back. We have never had this long sick leave, but we have to come back, but to take care of our patient, and we have to take care of ourselves also, because we see the surrounding. A lot of doctors are infected. So we have to take care of the patients while taking care of us. As you said, if you don't have a PPE, you don't go. If you are not completely protected, you shouldn't go. If you don't have these facilities, you shouldn't start working, because it's very, very crucial. If you go there and you got infected, your patients also will be at a very high risk if you already had infection. So again, it's like a double thing. You go there to help the patient. Sometimes you might go there and hurt the patient if you got infected, because you will never know when you get infected. And once the symptoms happens, it means that you have this since 1 week, and all the patients you have seen since 1 week might be exposed and might be infected. So again, it's very important, yes, to help the patient, but we have to be very careful. If you don't have the facilities, I don't think we should go back. And maybe if the government will, classify that, who will go back, who is not, again, is decided yet. If the antibodies will help, if the patient who are positive and now they have no symptoms will help, I don't know up till now. But again, we have to be very cautious because of us and because of our patients.
This is very good comment, Professor Magdy. Sometimes we think that we should look to the condition by two things. Number one, different specialty. Some specialty they have to go back.
Yes.
ICU, tumor specialty, tumor surgery, all those they have no choice for the sake of the community. And the number two, we have to individualize the area, even between the ophthalmology center itself. I believe some ophthalmologists has to go back to work because they are safe in an office. For example, they only see a normal patient, and with the protective measure, they may be needed to go back. But those living in a hospital that a lot of COVID-19 patients are admitted, those living in a hospital when they receive a lot of those patients, I think maybe delaying the restart is wise. So the treatment or the management is not the lockdown, because
Yes.
you will face a lot of people arguing you, why you lock down?
Yes.
This is our work, our economy. We're gonna die later on. So it's not the treatment lockdown. The treatment is by two ways. Number one, educational and changing the behavior of restarting again and choosing which center has to start and not. And I advise all the Ministry of Health in all over the world actually to restart what they call it certificate for each center. So each center has fulfilled this certificate to restart during pandemic, they can go back again to open. And those who are really in a danger, maybe it is wise to delay it. So we have to differentiate between each specialty and each center to approach this in a very specialized manner. We will run a poll, but after we take your opinion, Professor Magdy, regarding the OCTA. How really important you think the OCTA it is? In the past, we was thinking, said, well, listen, the technology developed faster than our clinical appreciation. Right. But I think it has been available now for years. So the clinical application we have enjoyed the information that you shared it with us. So is it really mandatory now? Is it like a part of the fundamental items in every clinic, new clinic at least?
Let me answer that very frankly. The machine is now in the market for 5 years. And my lecture today, and I always like to give this lecture about the artifacts, because a lot of people are happy. We got the OCTA. We need a couple of lectures to start doing OCTA. Couple of lectures is not good enough. I mean, you have to be meticulous about OCTA. How long we are using a fluorescein angiography? Decades, 60 years, 70 years, and we are professional fluorescein angiography. How long we are using structural OCT, regular OCT? 20 years. Now we are much, much better in OCT. But a machine like this, screwing around, giving a wrong diagnosis, this is crucial. And you asked me a very good question. You don't do fluorescein angiography anymore. So you do OCT and OCTA, and you get a very wrong diagnosis, and you start treating patients based on them. Because all of us now, 99% can interpret fluorescein angiography. Am I right? 80% can read OCT very meticulously. But how many can read OCTA? That's why artifacts, the one I gave today, is not to tell you don't buy the machine. It's to tell you there is a lot of things to know, a long learning curve. And again, sometimes I have a referrer for OCTA with a very dense media opacity, very dense cataract, vitreous hemorrhage, and they ask for OCTA. This is not the proper thing. Even OCT, even fluorescein cannot help you in this. So again, OCTA is a very good and very crucial in central area like macular disease. You can avoid injecting the patient, especially the patient who had allergy, has been injected before and they have reaction. The patient is old age, renal failure, asthmatic. I always hate this when I start doing fluorescein angiography. But OCTA can help you a lot. I mean, 50% of this patient you can avoid injection. But you have to know.
Just ask something about DME, because we have published few papers. The main advantage is that you can see the superficial and deep vascular plexus. And in diabetic patient, also in DME, we found that the one that's affected before is the deep vascular plexus in diabetic patient. So you think that it's something that we need to really look at and can give us some information before we see clinical findings, like we can see some changes in deep vascular plexus before seeing clinical findings and start to treat the patient a little bit earlier. What do you think?
I do agree that diabetic and RVO, the insult of deep plexus, sometimes you will never expect that things are going in. And I will tell you something. 10 years ago, when we have patients coming with early diabetic retinopathy and they are not seeing well, and we have nothing to explain why the vision is not that good, even at 612, even at 2040, because of the insult at the deep plexus. I have a couple of cases who came to my clinic, minimal diabetic changes, 612 vision, and I cannot explain that. Once I did OCTA, I found very good insult at the level of the deep plexus without the insult to superficial plexus. There is no hemorrhage, there is no hard exudates, there is no many microaneurysm, only ischemia. And this is against the old teaching. We used to teach that diabetic retinopathy starts temporal to the macula, microaneurysm, hard exudates, and then you get occlusion and ischemia. Sometimes it's the reverse. You get ischemia at the level of the deep plexus. You don't see it by fluorescein angiography. You cannot explain it. And the PAM, a lot of patients are presented by PAM, paramacular acute middle maculopathy, and we never expect that the PAM is the cause of diminished vision, especially in impending vein occlusion. So I think OCTA is an addition to the diagnosis and final diagnosis, because we have to look at the deep plexus sometimes if we see a patient with the visual acuity is not correlated with the clinical findings. So at this moment, I do OCTA and I always find the reason there. So it's very helpful. Sometimes you said the patient, go home, I can't find anything. But doing OCTA is very helpful in these cases, and at least you avoid the patient further and further treatment for nothing. So this is very important. As you said, the retinal vascular disorders, the diabetes and the RVO, OCTA is very good. You need to know in the early cases why the vision is affected. In the PAM, a lot of patients now having PAM, even they are not diabetic. And I found a lot of patients with hypertensive retinopathy coming with drop of vision, and they already got a PAM. So it means that it's a very good addition in a very good hands. And I don't think up till now we should replace fluorescein angiography, but it's an addition. Avoid fluorescein when you have hazards or contraindication. Do OCTA, good interpretation. I think you will be able to do very good, 99% good diagnosis and good treatment, and start treatment depending on OCT and OCTA without the fluorescein angiography sometimes.
Thank you, Professor Magdy. We will have a poll now. We will launch a poll. I need from all the audience to participate, and please. The question saying is, I'm opening my clinic with a less budget. So I am preferring by OCTA with traditional camera or traditional OCTA without angio, but being able to buy a wide field camera. I need from all the audience to participate in this poll, please.
That's a tricky one. Commercial and clinical. Putting the commercial in the question, you don't have enough budget, and the clinical, who will win? Money or, science?
Okay. Till they end voting, we have a lot of people want to ask question or comment by mic, so we will try to give by order. So this is the end of the poll. I will share it with you guys. So you see, 68 say they prefer traditional OCTA without OCTA and buying a wide field camera. The other want a traditional camera but with a good OCTA. So the majority still believe that wide field camera is more important than the part of angiography in the OCT.
Basically, we are asking the periphery or the macula plays the major role,
So those preferring injections maybe prefer the macula, those want to get a feeling of the disease itself.
Those want to get the full picture. If you want to get the full picture. And second thing, I will be comfortable if I'm having something I can interpret, understand, I'm very comfortable with. If I know fluorescein and OCT, that would be good enough for me to diagnose and treat the patient. And they are right. If they don't have enough budget, they will send the patient for OCTA every now and then, but at least they will have the basic, the standard of care, the gold stone, which is the fluorescein and OCT. I agree. I totally agree. And this is for me because of
To be honest with you, I bought the OCTA because there is some offer in some machines that you can get a wide-field mosaic software. They can build it for you, so you can.
Do you regret it?
Not really, no.
Okay, that's a good one.
But I'm not sure if I was wise in decision. This is my question.
So you starting to regret it.
I bought a lot of things without regression, but it's maybe not the best choice.
I do
so
agree.
we will have Dr. Maha. Maybe she wants to have some comment or question. You can speak, Dr. Maha, with us, please. Unmute yourself if you want. Dr. Maha.
You can unmute her. You have the ability of that.
I already unmute her, but she has to unmute herself also at the same time.
I see.
She has to open the mic for her. So we will take also Samir Awad, please. If you can speak, unmute yourself if you want. I think they have an issue with then.
They cannot find where's the button. The button is down there on the screen, down there on the left to unmute yourself, probably.
Exactly. The button to unmute yourself is down on the left. So
press
Maha
on the screen.
And Samir, they are on live now. They can speak whenever they unmute themselves. We have a question from Dr. Alessandros Papayounis. How you think it will be our timetable with the COVID, and how much time for a visit, for a cataract, IVT, etc.? You think we will need to work in a double shift, Professor Mario?
Yeah, so the point, so this is very important, but probably we need to work even Saturdays, probably Sundays, you know. So the point is we will have few patients in the clinic, probably one every 30-40 minutes, because then we need to have time, you know, to clean everything, and then we can't have many, you know, patients same time in the waiting room. And so that's why I think we will go towards you know, hub and spoke. So that means we will spread our activity not just in our clinic, but also in few centers around that are doing, you know, clinic as well, and not only in our hospital. So in this case, you know, the telemedicine, we will help a lot, because what I think in the future, probably telemedicine that is already present, will run faster, you know, and so we will have a lot of activity that you know, we can do remotely, and like just getting imaging on picture with the technicians, not in the hospital, but you know, in the, you know, spokes around, and in the hub probably we will have also, you know, the like virtual clinic, because most of the patients are just follow up, you know, and so we can see the OCT or imaging you know, in the clinic. But the point is not just you know, it's to don't have too many patients same time in the clinic as we had until 2 months ago.
Okay, we have another intervene, Dr. Rayan Sharif. You can please
hi, this is Dr. Anas Sharif, Dr. Magdy, and Dr. Mario. Thank you very much for your Romano. Thank you very much for your presentation. I just have a question regarding OCTs. There's a recent publication that looked at perfusion maps. Is that the same as density maps? And is it looked at usually at the deep or superficial plexus? I just think there's a lot of application and research regarding this, because I think I read it's a software. I don't know if it's built in or it's each center has to find an algorithm to create it. So any comments regarding these two things?
Yes,
Dr. Prof. Magdy, please.
Yes, there is density map in some of the machines with the numbers, which give you the flow in this area in a certain time, but only in the out of the commercial. The OptoView is the best one because they have a density map for the superficial and the deep plexus. And only Topcon, the sweat source, had the superficial plexus. Some of the other machines had only superficial plexus. But the problem is each machine has its own. If you do one with the one with the Topcon and then you repeat it with the OptoView, numbers would be completely different. There is no standardization for this up till now because they are not using the same algorithm. You know, the SADA, which is split spectrum amplitude. No, the OCTA is in the sweat source. They are different algorithms. Full spectrum or half spectrum, it's completely different. So again, the built-in algorithm for different machine is different. So you cannot compare different machines with each other. So again, there is no standardization, and the race now is to find out if you can standardize the picture and say this is the numbers you will find in any machine. And I don't think it's available up till now. Like the OCT, we used to know the layers and the thickness of the RPE and where you measure the macular thickness, either from the ILM to the Bruch's membrane, or you are including the RPE. So again, there is no standardization, and you have to stick to the first machine if you are following up a patient with a low flow, and you have to stick to the same type of machine. There is no way to do that up till now. That's why we still say we are developing, and it's still a lot to do in the OCTA.
Thank you very much, Prof. Magdy. And Dr. Mohammed Hazzazi, can you please unmute yourself?
Yes, Abdullah, do you hear me?
Yes, I'm hearing you.
Yes, good evening for everyone. Professor Magdy, Professor Mario, very nice lecture. I do have two questions. The first one is about PAM. Nowadays, we hear a lot, this diagnosis more than before. So the question, do you think that it was like overlooked for decades, for a long time, and now just with the new technology and new machines, that it become more, detectable clinically, or with the help with the ancillary test? This is the first question. The second one is regarding the, there has been many papers talking about inactive choroidal neovascular membrane, which showed in the flow chart some activity, while these membranes did not show any leaking on the fluorescent angiography, no fluid in OCT angio. So how do you put this together if you are going to whether to treat the patient or just observe based on the which modality that you will rely on?
Mohammed, Prof. Mario, for the pandemic question.
I think, SARS, we know that MERS, SARS was already around, in back, 6 years ago, both of them. And, but SARS-CoV-2 is different. And we know that, depends on the, how many, the spreading of disease is different. And so what we think that is something new, is not something that, because we never had this, pandemic with so many, deaths, and with, so the infection that had, really clinical findings like this one. So I think it's something new, it's completely new, and at least for us in Europe, I don't know if in China probably was already present, and it was like MERS or SARS, but as a SARS-CoV-2 is, I think, is completely new. And so I think probably the number are underestimated in Europe, but still something new that was not present before, I think.
Prof. Magdy, for the choroidal membranes?
The question he's asking about, you find the CMV without any signs of activity, no fluid, no hemorrhage, no exudation. This is a very good question, because this is what we call silent CNV. And this is only detected by OCTA, because we do OCTA, it's easy to catch the membrane. There's a new vascular membrane, but there is no activity. What's the meaning of activity? There is no arborization, there is no much flow inside the membrane, but it is there. And there is no reflected signs on the structure OCT. We don't find cystoid edema, diffuse edema, or sensory detachment. And on the fluorescein, there is no leakage, because these membranes are always hidden under flat and irregular RP detachment. So we call this silent or non-exudative wet AMD. And I had a lecture about that in Dubai, if he remembers. But this is a very good question, because we are following only these patients. We don't treat this patient. We find out that this patient might keep very still, without any complications, without any visual affection for years. So the only thing is to follow them up. And once the structural OCT start to show any signs of activity, like minimal fluid, like elevations, like focal edema, we start to treat them. If the OCTA also showed increase in the size or the flow of the CNV, we have to start treating these patients, because they might keep calm for a long time. But once they start, we have to treat them.
You think it's a matter of pericytes around the vessels? Because probably I know that there's some company that are working also on the drug in order to have, you know, not neo vessels, but vessels that cannot have leakage through. So you think, you know, we will have soon some drug that are helping us, you know, in this way, or not?
I don't think so, because my theory, I don't know if it's true or not, but my theory is this is a very early stage of CNV. This is what they call friendly vessels, which I don't agree on this term. They are friendly because they are helping the RPE on their action and their pump. That's why they don't show any manifestation. But once they are aggressive and they start to attack or penetrate the RPE, sometimes it is the active CNV. And Dr. Rosenfield, when he was here in Cairo last year, he was speaking about friendly, or, you know, non-exudative new vessels, which we have to watch not to kill, because they are good for the health of RPE. But in my opinion, this is a CNV which is very silent or very quiet, and one day, like a ticking bomb, it will work and it will cause the manifestation. Because what brings the patient in for CNV? The blurring of vision, or the drop of vision, or the symptoms like metamorphopsia. This happens when the complications happen: fluid, hemorrhage, exudation, elevation. So once the CNV is formed, there is no way to know it's there or not. But with the help of OCTA now, I always examine the other eye of active CNV, and in a lot of patients, I find flat irregular RPE attachment harboring a very tiny complex, which I don't know if it's a new CNV or it's just the beginning. So in my opinion, I would follow up. I have a patient following up for 3 years, having this silent CNV in both eyes, and nothing happened for 3 years. The same flat irregular RPE attachment, and this patient is 75 years old. And I did her phaco recently, and I was afraid that I will, you know, activate the CNV. It was not activated. So it means they might be there for a long, long time before the RPE start to decompensate, or they penetrate the RPE and they start to cause the complication. This is my thing in my mind. But to reach to them and flatten them down, I don't know if it would be helpful or not, because I've seen my cases following them. There is no harm. There is nothing. There is no complaint. So the patient is not complaining, and I'm just following them up to see what will happen for them. And I have only one patient during the follow-up who aggressively started to have this, and she missed the follow-up, and she came with an active CNV with a drop of vision to 660.
Okay, so you insist those cases has to be really followed up nicely, otherwise it may exudate without notice, isn't
Monitor.
it? Okay, so another question for Professor Mario. In France, I think they have developed an application during the pandemic time to follow up the changes for the AMD, just to minimize the non-needed visit to the clinic. Have you any idea regarding that, Professor Mario, or tried?
Yeah, the AMD is one of the, you know, the disease that we can monitor with the virtual clinic, but at the same time we need imaging. So Now you know that mainly we need for the telemedicine AMD, the metamorphopsia and the visual acuity. So we know that for metamorphopsia, we can use M charts or D charts, okay? And now are available on tablets. So not just so a matter of quantification with the of best corrected visual acuity, but also the quality, so metamorphopsia. And you know, there are already paper on D charts. The one was published by McGowan, Jerry, and Retina, and for the M charts by Ishida. So and now there is also a paper published in PLOS ONE, April this month, okay, about the telemedicine and the visual acuity. So I think we need to have, you know, for AMD, the visual acuity, and on the other side, we need just the imaging. And we are trying now to, you know, get this imaging, you know, in another place, not inside the hospital, in our clinic, just with the technicians, and then we try to, you know, match both together in a virtual clinic. I don't know if, you know, still there's something that we need to prove that is effective, because you know, we are not seeing the patient by ourselves, but sometimes for the follow-up can be enough. Or if we think that is not enough, looking, you know, the two things together, we can still ask the patient to come to visit us face to face. But, you know, like glaucoma, same things, you know, we can see the thickness of RNFL and, you know, other measurement. So, but I think we need to go in that direction. Okay.
This is take us to the next slide. Actually, we start with the buyer in developing an application, and they are very active in that field. Actually, like when the patient go in, he register his email, his contact. Then do you see the screen?
Yes.
So whenever he enter the application, he fill a question, then another investigation virtually, and by answering this questions and the virtual test, he get categorized for the doctor dashboard. So this is the doctor dashboard, and after that, we can really differentiate between the patient who is in really need to come, building on the answer of the question. So also this is the diagram of how the flow chart of the patient and the information is seeking. So when the patient log on, there is two different dashboards, one for the patient, one for the doctor, and the patient has to follow the question, tell the answer, then he will submit the answer. Then he will get categorized by the system, and the doctor will try to follow him. This system already established for AMD. But in our community, we have diabetic macular edema in which there is no system. What do you think that could be very helpful in that thing? I know that metamorphopsia is more for AMD more than diabetic macular edema, but I think also near vision get affected in diabetic macular edema more than the far vision. Any comment, Professor Magdy?
I don't know. It's still, I mean, it's a very good to start doing, like, you know, scheme to get the patients in to start working, but it depends on the culture. I think it depends on the areas. You said they started that in Europe, right?
For the AMD.
Yes, but I think in our area it might be a little bit different for us, because in there they have the health system, and they care a lot about, you know, coming in time, injecting, treat and extend. In our areas, probably the general health is more important, because, you know, from the social part, if anything happens to the patient or he died from, you know, infection, not from the eye, they start to think differently, that this patient came in very early and he could have been avoiding this, living longer even without his sight, for you know, without infection. What do you think?
Yeah, I think you are correct in part of it, but it's still having the data and knowing which patient
should come in. Yes, I do agree. I do agree. But
this is
it's going
will
to
make
be
the
a
flow
bit
easier.
difficult for us to do that. Maybe, I mean, it might be a little bit difficult for us because we might lose contact with the patient if the epidemic happens. You know, it needs a lot of, you know, insurance system which has logged every patient who's injected all over the country. But sometimes we lose number of patients where they are not, you know, the system is not covering every part. But it's a very good start to work like this, and we can apply this later on if the epidemic is, you know, getting less and less, because as you have seen, everybody's afraid, even the doctors, to go back to work because of the, you know, the psychic element, the infection. So how about the patients? It's going to be very difficult for them.
Any comment, Professor Mario?
The machine learning and deep learning started with diabetic retinopathy, because they can recognize the hemorrhages and the red spots. Okay, so probably the best thing is to follow the patient remotely with the picture of the fundus. I don't know if the visual acuity, because sometimes in a diabetic patient can be affected later on, okay? And so sometimes I think is not, the sensitivity, specificity is not so high of the, just best corrected visual acuity. So probably for MD, the vision probably is the first, symptoms. And so I will be more, I feel better if I can get an imaging at least of a diabetic patient, of the fundus, remote.
Yeah, we speak actually of the period of the pandemic. So at the time that you cannot see the patient, otherwise we all agree fundus photography, especially wide fundus photography, OCT is very important for decision making.
Yeah, but still, if there is no other possibility, I don't think that for diabetic, retinopathy, the vision acuity, is
it's not that important, right?
Yeah. Okay. Okay. So I think maybe we become at the end of the talk. We just want to share with you this this video. In the last part of the pandemic, we shared with you the tough measure in which to protect yourself from a confirmed COVID-19. While sometimes if you get in contact with the suspected cases, but he is not really confirmed one, we will see this video to describe those less aggressive measure. This video has been showing the donning and doffing of PPE for a suspected case, surgical mask, gloves, and just the yellow gown. So there is no N95 in that part, and no the shoes covered. Sanitizer is very important before and after. Video has been made by King Abdulaziz Medical City in Jeddah for everyone. Wearing mask and taking out mask, make sure it's sealed and there is no leak is very important. Taking out the gloves is very important. Make sure you take it from inside and don't touch the outside things. And also, sanitizer is very important. Taking out, trying to touch the inside part, not the outside part. Hand hygiene is always important. Taking the gloves, the mask is from inside. Try to avoid touching the outside face, throw it away, and sanitizer at the end. And that's it. So at the end, we would like to thank all of our speakers for staying with us and sharing with us their very important information. Thank you, Professor Mario R.Romano, for the valuable talk. Thank you, Professor Magdy Moussa, for the valuable talk. Thank you for all the audience, their poll voting and staying with us till the end. Thank you, everybody, and see you in other meeting, inshallah. It's always at Friday at 10 during Ramadan. Thank you for all the sponsors, all the share association with us. Thank you for National Guard, Pr, Saudi Retina Association, RSOS organization, and the live presentation.
Thank you, Dr. Abdullah. Thank you, Dr. Mario.
Thank you. Thank you very much.
And I'm sorry, I have my granddaughter sitting with me. She knocked on the door 20 times up till now. That's why I go and pick her up. It's 2 hours now. So
this is the best.
She's live image with us now.
This is the best image.
Okay. Thank you so much.
Take care.
Bye-bye.
Thank you very much for coming.
Thank you. Thank you,
Abdullah.
Thank you,
Thank you, Dr. Mario. Bye-bye.